Thank you. Just grabbing a pointer. So modern trauma care, I would guess that I could drop the modern part, because when you talk about antiquity, really trauma care has really ramped up in terms of complexity since World War II. I mean, you go back even 150 years, the treatment for trauma had been amputate that limb that was injured and hope that the patient doesn't get an infection. You just have to look back at Civil War history to know that we've come a long way just in the last 150 years. So when we look at the entire span of humankind, remember humans have been suffering trauma since the first day that they could walk, and it's continued all the way through. It'd be great if the clicker would click, but so I have no financial disclosures in any of the products I'm going to discuss, and I want you to understand that the individuals that we'll discuss throughout the cases that I present here are going to be purely in a historical perspective. We won't go outside of the historical perspective of each of these individuals. So case reports. Adult learning is focused upon either doing or being able to put things into a clinical context. And we use case reports all the time in adult learning, not just in medicine, but across all specialties. So if you go to business school, in business school, a lot of the advanced principles that you learn are presented to you in case conferences. So a classic example is Nucor versus Bethlehem Steel. Nucor is a small company that decides that what they're going to do is they're going to build a bunch of small mills where they're going to create steel all around the country, and they're going to compete with Bethlehem Steel, the giant of the industry at the time. And basically the principles that you learn from that case are innovation and employee-employer relationships, because that's how Nucor ended up becoming so successful and ended up toppling Bethlehem Steel. It's a lot better to sit there in a class, read about the comparison of Nucor versus Bethlehem than some crotchety economics professor stand up in the front of a business class and explain to you by PowerPoint the principles that they're trying to get across. So case reports, we are all very aware of because we deal with case reports all the time, both in testing and in studying. USMLE focuses a lot on case reports. In medical school, a lot of what you learn comes from case reports. Even now, everything is becoming case-based, where they're teaching all of anatomy, microbiology, physiology, all based on case-based methods. Just look at your SCORE curriculum. SCORE presents you with a list of principles, right? And then provides cases that back up those principles. And we use oral exams. Oral exams are done for certifying surgeons, and this is done in a case report basis. So case reports are integrated throughout everything we do. We're all aware of the 4-week-old with non-bilious projectile vomiting, or the 39-year-old with alcoholism and hematemesis. Classic cases that we've all studied throughout medical school and have talked about during training. Even at grand rounds, we use case reports to present concepts and ideas. So we've heard about thoracic outlet syndrome and the cases that are associated with that. We've heard about pediatric fetal surgery and some crazy things that are done intrauterine in order to get good results when the child's born. We've taken it in other directions. We've heard about case reports of presidents that were killed or almost killed to highlight other principles of trauma. And then most recently, we have heard about how Teddy Roosevelt's house in New York relates to the delivery of health care in immigrant populations. So lots of different variety of case reports that we hear throughout grand rounds, and today is going to be no different. So I will provide you with cases to highlight modern trauma care. The patients that we will present, you're probably very familiar with. I will give you some background and some context to these cases, sort of to help you have a better understanding of it. And all of these cases are going to be looked at as if the patient presented in modern times with modern trauma care. I can't use the standards of care at the time. All of these cases actually were fatal. So all these patients died. The question is, would they die with modern trauma care? So first case, it's a 46-year-old man. He's Italian. He presents to the emergency department after with some loss of consciousness and a penetrating injury to the posterior left shoulder. Pretty simple, pretty straightforward. Unclear of what the circumstances of the penetrating trauma are. Could have been in combat, could be war, unclear, could have been a hunting accident. We're not 100% sure, but it's something. And in this case, the actual circumstances that go with the mechanism don't matter as much as the mechanism itself. So, something that's very modern, advanced trauma life support. We all learn ATLS. ATLS is integrated. You need it all to be able to graduate from residency. ATLS is only about 30 years old. The first actual ATLS class was actually given in 1980. It was developed in 79. The college adopted it in 1980, and it's just been around since the 80s. It's not something that's been around for a long period of time. ATLS is based upon the ABC principles of airway, breathing, and circulation. We mentioned the circumstances of war because the military, certainly out on the battlefield, has changed that paradigm to XABC, meaning address the exsanguinating hemorrhage before you address the airway, since that's the leading cause of death. But in our principles right now, we all still practice ABCs. So for this patient, they roll through the door, had a loss of consciousness. GCS is a little bit decreased, but they're not unconscious. Airway's patent, clear breath sounds both sides, normal blood pressure, absent pulse in the left upper extremity. So you expose the patient, no neurologic deficits, you find a penetrating injury on the back. Now you go to the adjuncts of the primary survey. And the adjuncts of primary survey are chest x-ray. So here's your patient's chest x-ray. Take some artistic license. He does not have pneumothoraces, even though it looks like he's got pneumothoraces on the imaging. And you see a foreign body up there, up near the left clavicle, and it turns out that he's got an arrowhead stuck in his clavicle, below his clavicle. Obviously, probably the most likely source of his pulseless extremity is this arrowhead. Everybody knows after you do the adjuncts to the primary survey, you then proceed on with the secondary survey, which basically is a full head-to-toe physical exam, examining the patient, looking for other injuries. So here's what you have. This is your patient. Little worse for wear, other than just the penetrating injury, but that's him. So who is this patient? There's his injury that you have on the back, kind of tangential wound, where at the end of that wound is where the arrowhead is. So this is Otzi. He's a 46-year-old man. He basically lived about 6,000 years ago in a beautiful place up in northern Italy, right near the border in the Alps. Otzi is about 5'5", 110 pounds. He lived within 37 miles of his region in northern Italy. Didn't travel any further than that. Spent a lot of time walking. He was certainly not a laborer based upon his upper extremity musculature. He did not labor, he just walked, meaning he was either a chieftain, a hunter, or a shepherd. He was dressed in a goatskin coat with stripes. He had shoes. He carried a hatchet and a knife with him. He had atherosclerosis. He was lactose intolerant. He had whipworm, which is pretty common, but he also had a form of Lyme disease as well. What he was doing up there, we're not 100% sure. He was actually found in the early 90s embedded in a glacier, and as the glacier melted, they ended up finding him. This is what he looked like based upon genetic testing and reconstruction. That's what Otzi would have looked like, kind of short. They actually took his DNA and traced it back to 13 people who are currently living in this region of Italy, so his lineage continued to progress even after he died. And like all trauma patients, he ate before he suffered his trauma. He didn't eat at Del Taco, but he did have a meal of venison and some grain, and then before that he had a meal of ibex and grain, so he was certainly a meat eater and was eating before he suffered his trauma. So the question now becomes, what do we do for Otzi? Does he need a head CT? He had a loss of consciousness. So if we go back to some of the modern trauma literature, the Traumatic Brain Study Network out of Korea, which was done actually in conjunction with the folks here at UC Davis, went through patients that suffer minor traumatic brain injury and tried to identify characteristics that would make them more likely to have findings on their CT scans, which would then in turn say, these are the patients that should have CT scans. Otzi met the first two criteria. He had a decreased GCS and he had a loss of consciousness. Not sure if he has a severe headache. He certainly didn't seem to be vomiting according to what they found around him, so he didn't meet that criteria. He was less than the age of 64. He may or may not have been intoxicated. They're not sure. They actually were able to find intact red cells, but they weren't able to do serologies on his blood. Dangerous mechanisms really auto versus pedestrian or high-speed motor vehicle crash, which he was not involved with. He does not have a basilar skull fracture. Questionable whether or not he had a neurologic deficit. That may have been from the arrowhead because it's likely that it injured part of his brachial plexus when it went in. But amnesia, post-traumatic seizures, coagulopathy, or supraclavicular trauma are all indicators of these are patients that should have their head scanned. If they don't meet these criteria, the likelihood of having something on their head scans are small. So for this patient, we run into a dilemma. We have loss of consciousness who needs his head scanned, but also has a pulseless upper extremity. In patients where you have these decisions to make, you have to ask some questions. The first question is the decreased GCS from shock, or is it from traumatic brain injury? He's got no hemothorax. He doesn't have a bunch of blood on his clothes. The arrow went in. There doesn't appear to be a lot of bleeding, and he has a normal blood pressure. Likely, his decreased GCS, if he has one, is not related to shock. So it's not related to hemorrhage. If we do take him to the CT scanner before we fix his arm, are we going to be able to do anything? Well, if he has a subdural that needs to be drained, or if we're planning on giving some heparin during the vascular repair, we're going to want to know what's going on in his head. So ideally, we would take him up to the CT scanner and get his head scanned before we end up doing his vascular repair. What's the urgency of the extremity? Let's pretend, for argument's sake, that Otzi wasn't laying on the mountain for 6,000 years and he came right in. We're within that 6-hour window. It's probably better to end up doing a CT scan. So here's the CT scan of Otzi's head. Brain's a little shrunken over time, but there is evidence that he has some blood and intraparenchymal hemorrhage posteriorly. No evidence of skull fracture, which means Otzi probably banged his head when he fell to the ground and didn't get clubbed with some blunt object. You would think that if you're an Ice Age man and you get hit in the back of the head with a weapon, that it's going to be enough to break your skull. So nothing that we need to do right now for Otzi's head, so it's take him to the operating room and address this pulseless extremity. Now, in modern care, how do we address pulseless extremities? Well, the real push now is to try to do things endovascularly. And this is a paper from Dr. DeBose, who addressed a similar problem of pulseless upper extremity after penetrating trauma, where they did it endovascularly. They were able to get a wire across the injury, then end up placing a stent, and had great outcomes. And then they went through and reviewed the literature and said, you know, if you can do this endovascularly, the outcomes are pretty good. In fact, they're good enough that they're comparable to open repair. It's just length of time for follow-up is just not as readily available as what it is for open repair, since open repair has been going on for decades. For Otzi's case, however, it's a little more complicated because he has an arrowhead stuck in the artery, and it's not just a simple hole in the artery. So for Otzi, you're going to have to go in and do an open operative repair. An open operative repair for subclavians are not simple. This upper picture shows how easy it is to get access to it on the right side, meaning you resect part of the clavicle, the vessels are there, you should be able to have access. Unfortunately, Otzi's is on the left side. These images come out of USC. I'm not sure how the anatomy is down in USC, but it is not easy to cut out the clavicle and have the artery sitting right there when you do a left-sided subclavian, because this arch goes from anterior to posterior. It doesn't go from medial to lateral. So it's actually a rather complicated open approach, which if there wasn't an arrowhead, the argument could be made to do it endovascularly. The problem is you gotta get that arrowhead out. And then you also have to worry again about what's gonna happen with the brachial plexus and did he injure any of his brachial plexus. So to wrap up the case, he's 46, shot with an arrow, blunt force trauma to the head, has a TBI, has a pulseless extremity. If we were able to bring him into a modern trauma center, would he be a save today? Absolutely. We'd be able to save him. He might have to go to some rehab for his traumatic brain injury, but Otzi would still be alive. Good for him.
So would you be comfortable giving him heparin for that head injury?
So probably not, because it looks like it's intraparenchymal, and those will typically blossom over time. If you give them systemic heparin during the operation, probably would run the risk of having that increase. He has a lot of space in there.
No, but I mean, going through the intellectual.
Yes, no, probably not.
How do you put together the humerus fracture?
Probably from the fall. There's a question about how he was rolled by the glacier. They didn't have any soft tissue trauma, so they were suspecting that was because it got crushed in the process of the glacier rolling him over time. They don't think he fell where they found him. They think that he got pushed there.
So what did he die of?
Exposure. So they thought that he had bled, but he probably got weak, potentially from his traumatic brain injury, and fell there and laid there. He's at 10,000 plus feet. So they think that he just laid there and was mummified.
Another thing is that we know for sure that he transacted that artery.
Yes.
Okay. Let's say if he does not, what is the modern practice? Are you going after the foreign body or you leave it alone?
So if he's shot with in modern day, if he has a round that goes in that didn't cause any injury, we don't go in to fish out the rounds. Bullets are a little bit different than arrowheads because of the spin to them. They spin into the tissue, and they usually cause a lot more morbidity trying to cut out foreign bodies than you do leaving them in. The other issue that you run into is the foreign bodies are never right where you think they are. So that superficial round that you can feel or maybe see on x-ray is never very superficial. It's usually pretty deep. So the next case, this is another Italian man. He's 50 years old, status post assault with multiple stab wounds. The best way to kind of imagine this is it's a prison stabbing is essentially what it comes down to. Multiple assailants, one patient, stabbed a bunch of times. This is your patient. So the Emperor Julius Caesar. Caesar actually had an unbelievable life in terms of he served as a politician, he fought with pirates, he was a military general, he did all these things, and then ultimately he died a bloody death like a prison riot, bleeding on the floor of the theater where they had the temporary Senate set up. During Caesar's time, Caesar as a general eventually was sent out with his legionnaires and conquered most of Europe, or Gaul as it was known at the time. He actually even crossed the English Channel and went into England, although he didn't leave anyone in England after he went there. The Romans eventually went back, but he was a great conquering general. And at the time when you're a conquering general, you end up becoming governor of the land that you conquer. So he was actually governor of Gaul. He had his army. The problem is that in order to get that position, he had a lot of political alliances that over time began to fall apart, and he lost his political allies. So as he was gaining all this power in Gaul, the leader of the Senate, Pompey, didn't like how much power he was getting, and they summoned him back to Rome. And basically, they're going to bring him back to Rome to put him on trial and to execute him. So one of the two most important events or most famous events of Caesar's life came in 49 BC when he's standing on the north bank of the Rubicon, and he's deciding, does he cross the Rubicon alone, where he'll be arrested and then tried and executed, or does he break tradition, cross the Rubicon with his legions, which in turn would incite a civil war? And what he did is he took an in-between approach where he left most of his legions. He took one of his legions, which is about 5,000 men. He crossed the Rubicon and in turn incited a civil war in which he ended up routing the legions that were in Rome, since they were not battle-hardened legions like the 5,000 men that he brought. He ended up killing Pompey, became head of the Senate, and eventually emperor. This is a painting of him crossing the Rubicon. It's a little bit misrepresentative. It's shown as him crossing the Rubicon is going to lead to death, destruction, and chaos for Rome. And it did lead to chaos to Rome for a couple years during the Civil War. But once the Civil War ended, Caesar was actually extremely popular amongst the people of Rome. Caesar actually adopted the policy of, we're not giving back to the senators, we're giving back to the lower class and the middle class. He actually really built up Rome, and he was very popular with the people. And along with the popularity, he ended up gaining more power, which worried the other senators, eventually making himself emperor. And what their real concern was that he would become king. And he actually did things to try to avoid looking like he was becoming a king, because unlike emperor, the king's lineage goes back along with his family. The emperor, once he dies, the lineage is a little bit different of who's going to assume command. So this is the most famous part of his life, the Ides of March, March 15th. They're having a Senate meeting because he's on his way to take the armies of Rome to fight the Parthians out in Jordan and modern-day Iraq. And he's having one last meeting with the senators before he ends up going off on this campaign. 60 senator conspirators decided that they've had enough of Caesar being in charge, and they went and they stabbed him. They stabbed him 23 times. The first couple stab wounds, apparently he tried to get his dagger out when they started stabbing him, caught him in the arm. The third one caught him in the chest. He fell to the ground. His conspirator stabbed him, and then they let him lay there for 2.5 hours until his servants finally came in, got him, and took him off to be buried. That's kind of sort of what an artist's depiction of it looked like. There's probably a lot more people crowded around. Like I said, very much like a prison fight. So he waited 2.5 hours. How about in modern care? If they had just run in, the servants had run in, picked him up, and carried him right off to a hospital in Rome, would he have done any better? Well, modern trauma says that the concept of stay and play, which is take and provide pre-hospital care, versus scoop and run, which is just grab the patient, throw them in the back of an ambulance, a police car, or a private vehicle, and get them to the hospital, actually has improved survival over the provide care en route. Several studies out of Temple show that scoop and run actually does better and saves more lives. And when they go back through and adjust it for severity of injury, the less pre-hospital care that's provided in these settings translates into better outcome. So grabbing Caesar and just dragging him off to the hospital would have been much better, certainly much better than leaving him lay there for 2.5 hours. There's a caveat to these studies, though. These studies, the actual transport time in these studies is about 10 to 15 minutes. So scoop and run works when you're in an urban setting close to the hospital without long transport times. It is beneficial to stay and play when transport times become longer. And this really is only for trauma. This is not for the patient who has a heart attack or the patient with COPD. These studies only go with trauma. Now for Caesar, he had a stab wound to the heart. So likely, if they scooped and ran with him, he'd show up at the hospital with a pulseless under CPR. So it comes up to, well, what are we going to do with a pulseless Caesar who's under CPR after penetrating trauma? This is a question that's been looked at by a number of individuals. This is reports out of East and West trauma, looking at what do you do for pulseless trauma after they present in terms of ED thoracotomy. Both studies agree if you suffer a blunt trauma and you're under CPR, don't do an ED thoracotomy. The patient's probably dead already. That's pretty clear and universally accepted. In terms of penetrating trauma, these studies are tough to read because there are so many variables. I think it's the Western trauma study, there's 4 different categories. Pulseless with signs of life, was pulseless with signs of life, not pulseless. You bang your head against the wall trying to read them. Essentially, to distill them down, what it comes down to is if the patient, a lot of them use 15 minutes. If the patient had signs of life within 15 minutes, then go ahead and do the thoracotomy. Many of you know time is not very reliable. Many of you think that I've been standing up here probably talking for an hour now when it's not really even been that long. So time is not really the way to go. What they did find was that if they could identify that the heart was dying or dead, is essentially what they found, then you'd avoid the ED thoracotomy. And the way that we know that the heart dies in trauma is it kind of just slowly turns itself off. So the QRS widens, the heart rate slows down, and the patient's dead. So avoiding time, it really comes down to a fact of if the QRS, if it's a wide complex bradycardia, patient's probably dead and doesn't, regardless of the time, does not end up having to go undergo a thoracotomy. Caesar, laying there for 2 hours under CPR, would not have had a thoracotomy unless he showed up right away. Now, that's for thoracotomy. Remember, thoracotomies are addressing either A, some penetrating cardiac injury, which in Caesar's case he had, or B, intrathoracic hemorrhage. And finally, it's used to cross-clamp the aorta to help address non-compressible truncal trauma. Whereas now there's Reboa, which can be placed through a groin stick, and the balloon can be inserted into either zones 1, 2, or 3 in order to stop that non-compressible hemorrhage, thereby avoiding having to do a big ED thoracotomy in order to stop hemorrhage. Folks in Maryland and Houston are using this in their resuscitation algorithms now and are using it as alternatives to patients that they would normally open their chests on. They're placing Reboa and are reporting good results, but certainly not done in a prospective randomized method. But they are reporting that there's good results with Reboa in terms of just opening the chest to do CPR, which they're showing is not as effective as closed chest compressions, or to control hemorrhage in the trunk, which is being done now with Reboa. So the other problem that Caesar suffers from is he's massive hemorrhage. We need to address his massive hemorrhage. In modern day terms, we need to do damage control resuscitation, and we need to use the adjuncts of damage control resuscitation, which is TXA. Caesar has certainly fallen into the trauma triad of death. He is not only hypovolemic, but he is also acidotic, coagulopathic, and hypothermic, and we need to break this cycle or else he's certainly going to die. This is out of Iraq when they made sure that they accounted for injury severity. When they looked at only INRs of greater than 1.2 have a tremendously significant mortality associated with that alone when compared to INRs of less than 2. So this coagulopathy does kill patients. So how do we combat the coagulopathy? We do hemostatic resuscitation, replace like with like. This is a comparison. The red is fresh whole blood and the white is components in an adequate ratio. And what it shows is there's no difference if you give a patient 1-to-1-to-1 resuscitation versus fresh whole blood in terms of survival. So the y-axis is survival. They account for ISS in this study and show that components and fresh whole blood are equivalent. How much blood to plasma? Other studies that came out of Iraq and Afghanistan show the higher the ratio, the better. So the closer to 1-to-1. But if you notice, it's not 1-to-1. It's almost 1-to-1. It's about 1.5 to 1. So 1.5 of packed red blood cells to plasma is how we typically talk about it. The study, when they wrote it as plasma to packed red blood cells. But that's what you want to try to approach because you're trying to reconstitute whole blood. As you also know, within whole blood, there's platelets. Platelets are often that ugly stepchild that gets missed in resuscitation. But at 48 hours and 30 days, patients that get platelets actually have a better survival than patients that don't receive any platelets. And if you map it out in terms of a log scale, even within the first 24 hours, getting platelets ends up doing better for those patients than not getting platelets. We've heard about TXA. TXA is not a new drug. It's been around since the 1960s. What it does is it prevents the fibrinolysis of clot. So clot forms because of your innate coagulation. TXA just helps stabilize those clots. CRASH 2 gave TXA to all trauma patients. Many of those patients didn't actually receive blood. Many of them didn't receive any operations, but they saw us that they improved mortality. Over time, with the military experience and our own experience, it's been whittled down to indicators of who gets TXA. And really, who gets TXA are the patients that are bleeding. So the patient that's hypotensive from shock from hemorrhage, systolic blood pressure less than 90, the patient who you have to give a massive transfusion to, benefit from TXA, and the patients that go directly to the operating room. Because usually for trauma, when you go directly to the operating room from the ED, you usually have something that's bleeding. So those three indicators are the way that you decide who's going to get TXA and who's not. Obviously, Caesar would have gotten TXA. So Caesar suffered 23 stab wounds. Unfortunately, one of them was a fatal cardiac injury. He had massive hemorrhage. He laid there for 2.5 hours. In modern day trauma care, if he showed up, he would have likely been pronounced when he showed up, and we would not have been able to save him. The question just becomes, if he didn't have the cardiac injury, or if he showed up at the hospital that was right across the street quickly, could we have done something? Maybe. That's why I didn't give it a definitive no. We wouldn't have been able to save him, but likely we had not been able to save Caesar. So the third case, 33-year-old man, status post-assault. He is hypotensive with multiple penetrating injuries to the extremities. So before I go into this case, we need to talk about the importance of understanding the mechanisms for trauma. Mechanisms helps you identify what the potential injury pattern is going to be, helps you kind of understand what you're looking for. Granted, we're kind of keep an open mind that anything can happen, but certain mechanisms come along with certain injury patterns. This is the classic whiplash pattern after a motor vehicle crash. We all know those. Assault's a little bit different. You need to understand a little bit more about the assault mechanism, because an assault with a baseball bat is certainly different than an assault with a machete. That's different than assault with brass knuckles. So having an understanding of what the context of the assault is becomes somewhat important. Certainly becomes important in this case. We're going to talk about historical Jesus versus the dogmatic Christ. All right, so historical Jesus is based upon biblical scholars of what they're able to piece together. There's two main facts that all biblical scholars across the spectrum agree upon in terms of historical Christ. One, he was baptized by John the Baptist, and number two, the Roman governor of the region at the time, Pontius Pilate, ended up having Jesus crucified. So let's talk about the mechanism of crucifixion. Crucifixion is probably one of the most dreaded mechanisms of death. It takes all the bad things of a bunch of other ways to die and combines it all together. So it takes the fear of the victim of being burned at the stake, combines it with the feeling of drowning, and couples it with total public humiliation, because they're basically out there in public in terms of crucifixion. Crucifixion was not something that was done behind closed doors. It was done right outside the city walls for all to see. And in fact, the Romans made a habit of just crucifying people along roadsides so that it was able to instill in the population the fear of eventually being crucified. And it really helped solidify their power in these regions that they were able to end up conquering. So the mechanism of crucifixion will refer back to a lot of the art. The art of Jesus' crucifixion actually has a lot of mechanical relevance to it. There's a lot of falsities to these images, but there's a lot of things that we can take from them. So one of the classic things that you would notice if you looked at these types of paintings is the knees are always bent. That is true in terms of Roman crucifixion. The Romans always had the victims crucified with their knees bent, and I'll tell you why that is in a minute. The thing that's not true is the nails don't go through the palms of the hand, they go through the forearms. And it's not just nails up onto the pedibellum, which is what it's called, but they also tied the hands, because the Romans wanted this to be an efficient mechanism of execution. They didn't want the victim to fall off, so they not only nailed them, that adds the fear part of it, but then they tied the arms to the cross beam just so the patient wouldn't fall off if they struggled to pull their hands. This is what the crosses looked like. They're not really crosses. So they had a stipes, which was usually mounted, which is the upward vertical piece that's about 6 to 8 feet long. And they had those mounted outside the walls of the cities where they would end up doing the crucifixions. And then what they would do is they would bring the victims or the criminals or whoever into the court. They would try them in the court inside the walled cities. They would take the crossbeam, which is the patibellum. They would tie it to the victim, hence where they don't have to tie them when they're up in place. And they'd make them carry that crosspiece out to the stipes, where they would then nail their hands to the crossbeam and then hoist it up into a notch in the stipes and mount the patient or the victim on the cross, if you will. There's a little stand for you to put their heels on, and then they would nail their feet right there at the stand. And the stand was usually such that their knees were able to be bent. They did used to hang little signs over them so that passerbys would know, A, who it was and what they did, and know that if they did the same things, that they could expect the same fate of hanging up here, withering to die. The physiology of crucifixion is interesting in that you can imagine your hands are outstretched at the level of your ears or higher, meaning your chest cavity is open. So your space in between your ribs have expanded and your diaphragms drop down. What it does is it reverses the cycle of breathing. So it makes that inspiration is really easy because your diaphragm's already down. You can easily take a breath in. The problem is you can't breathe out. Try to open up your chest and try to have a bunch of exhales, and you can't do it. You essentially generate auto PEEP for yourself. So what the victims used to have to do, and why their knees were bent, was if they straightened out their legs, they could take some of the tension off of their arms, and they'd be able to exhale. But you can imagine you're pushing with your heels that are nailed to this piece of wood and trying to rotate your hands so that you can bring your elbows in so you're able to exhale. So basically what would happen is over time you would just asphyxiate yourself. As CO2 would build, you would end up just suffocating while you're hanging up there. Now, the Romans were experts, and they had a lot to do. So they couldn't spend hours and hours standing out here while they had patients crucified. So what they did is in order to master the technique, they added some extra little things to make the process go along a little faster. This is such a painful process. As I said, Caesar fought pirates. Caesar actually got caught by the pirates, and they treated him pretty well, but the whole time that he was caught by the pirates, he told them, when I get out of here, I'm going to come back and I'm going to find you, but I'll be merciful to you. When he eventually became emperor, he ended up catching the pirates, and he had them all crucified, but what he did was he cut all their throats after they got hung up. That way they died quickly, because most of these patients don't die very quickly. If you don't add the Romans scourging, you end up hanging on that cross for hours after hours after hours until you asphyxiate. So what the Romans did is they added the scourge. So after you get tried, they then take you out to the courtyard, again with a crowd of people around. They strip you down to your waist, and then they have 2 legionnaires stand on each side of you and they whip your back. And it's about 12 tassels on these whips with bone or rock embedded into those. And they just basically shred the skin and musculature off your back, creating a large soft tissue wound, a lot of hemorrhage. They put you in shock. Then they take that patibellum, they tie it to your hands, and they make you walk out to outside the city walls where they hang you up and wait for you to die. Luckily, though, they've already put you into shock, and they've already made you somewhat acidotic, so the acidosis that builds with the asphyxiation actually doesn't take as long because, like I said, they have a lot to do. So in terms of Jesus, when you get him off of the cross, we'll say before he's actually dead, hypovolemic shock, respiratory acidosis, respiratory failure. He's got the penetrating injuries to all the extremities from the nails that they use for crucifixion. He has a large soft tissue injury to his back, likely has pneumothoraces, certainly has effusions just from the mechanism of the respiratory failure. And then tradition has it that Jesus ended up having a penetrating right heart injury, because basically what the Romans would do after they got tired of having you hang up there for a while, they would come around with mallets and they would smash both of your legs so you lost that ability to stand up and exhale. So they break both your legs and then you lose that ability, which helps the process go along faster. Tradition had it that he was already dead, so the centurion just stuck his lance into his side on the right side, not on the left as the images had it, and transected the right atrium. But we're going to pretend that that didn't happen because that won't be survivable, and that was post-mortem. So basically, if Jesus came in, he likely would end up having tourniquets because EMS and others wouldn't be able to staunch whatever hemorrhage was coming from those 4 extremity wounds in addition to the large hemorrhage from the back. So you might be able to control it with temporary measures of pressure dressings, but likely after that type of assault would come in with tourniquets in place. And tourniquets are interesting because while we don't think of these as modern, they actually have come back into vogue over the years. During World War II, what ended up happening was the orthopedic consultant in England was at a rear hospital, and what he would see is all these patients coming into England to these rear hospitals with tourniquets that had been placed and severe morbidity associated with the tourniquets. They'd have some limb loss, they'd have all this. What he failed to recognize was these were the patients that actually survived because they had tourniquets, unlike the patients that he's not seeing without tourniquets who had all died. But he only saw it from his perspective, said, tourniquets are so bad, look at all these morbidities that they're associated with, stop doing tourniquets. And that stop doing tourniquets actually started in World War II and continued all the way through until the early 2000s. People were just totally opposed to tourniquets. When if you look at it, the actual complication rate that comes along with tourniquets really is only about 0.5 to 1.5%, and even those numbers are a little bit questionable because what of the nerve injuries, what was caused by the injury itself and the patients now survived versus the tourniquet injury. So tourniquets are relatively low in terms of complication rate. They certainly save lives. In the Boston bombing, it was interesting, 67 patients ended up getting tourniquets placed. All of those tourniquets were makeshift tourniquets because Boston EMS at the time still didn't believe in actually carrying tourniquets on any of their ambulances. But once they ended up having the Boston bombing, they ended up having to do all these makeshift tourniquets, and now Boston EMS has adopted to carrying tourniquets on all their ambulances. So once something gets downplayed or a bias becomes against it, then it takes a long time for that bias to go away. So in terms of historical Jesus after crucifixion, he'd come in, certainly be in respiratory failure, need to be intubated. Likely would have decreased breath sounds on both sides, end up getting bilateral chest tubes. The massive tissue loss and tissue injury would require hemostatic resuscitation, very similar to Caesar. And then you'd spend a lot of time not only correcting the metabolic derangements that came with his shock, but you'd also have to correct the metabolic derangements that came with the asphyxiation. So basically, Jesus is scourged and crucified in the true Roman tradition, suffered hemorrhagic shock and respiratory failure. Would he be a modern-day save? He would be. As long as you ended up getting to them before the centurion jammed the lance into his side, you probably would be able to save him. It would probably be intubation, a long hospital course and resuscitation, but likely would be able to be saved. So overall, as you can see, different mechanisms, similar pathophysiologies of hemorrhage that are related to trauma. These cases from more than 2,000 years ago are great ways to highlight modern trauma care. The thing that really happens here is I reviewed for you 5 of the trauma protocol and guidelines that we have on the website. So I went through who over 18 should you CT their head. We went through the trauma arrest algorithm. We went through administration of TXA. We went through massive transfusion guidelines and CAT tourniquets. Those are the numbers. This is the website. Don't forget to read the guidelines that are on the website in order to know and understand what we do, certainly here. But remember, what we do here is not the UC Davis way of doing it. This is actually the literature-supported, evidence-based methods of delivering modern trauma care. So at the end, just take a minute to say thank you to those that have given everything, and I'm happy to answer any questions. All right. Great, thanks.
So, this is a great presentation and a way to compellingly teach what might otherwise have been some
A boring topic of going through guidelines.
How did you pick the trauma cases?
So I wanted to do something with Antiquity. The pathophysiology of crucifixion is always very interesting. There's been a lot of books and a lot of articles written over the past 50 years. It's very interesting to see what people had hypothesized was the mechanisms, comparing it to pseudo-crucifixions that still occur versus war torture, of what they were able to come up with. And then once you have that as a topic, you need to build other topics around it. There's plenty of other historical trauma cases that you could take and analyze in terms of case reports. Dr. Wisner does a great job of it using presidents, both dead and near dead. But you could do it for British naval officers. So if you look at the cases of Horatio Nelson, of what would have been done, could he have been saved? A lot of interesting cases that come up other than the auto versus pedestrian in Sacramento that you use normally to teach. So great, thanks. Oh, another question?
I just had a quick question about, so going back to the Caesar one, I was lucky enough in my training to have a couple of trauma patients that I was able to do a clamshell thoracotomy on that they could run like you not just to need that, but one of my M&Ms for those that kind of discussed, where do you draw that line between, okay, maybe this is too far versus, well, these are residents, and they need to get this training in this. How do you balance that?
Yeah, I don't think anything should ever be done because the residents need the training. The whole paradigm of ED thoracotomies is potentially in flux right now, in terms of having the ability, like I said, the reason to do ED thoracotomies is really to correct hemorrhage or pathophysiology in the chest. With Reboa coming into play, it's starting to replace the need to cross-clamp the aorta to prevent non-compressible torso hemorrhage. There are times where you open one side of the chest and realize the pathophysiology is on the other side. It's really hard to do bilateral thoracotomies in those situations, and you end up going to clamshells. You still do clamshells at times. Time will tell in terms of what the actual course of ED thoracotomies are going to be in the future. All right, thank you.